the curriculum, and it's drug interactions. So looking at drug interactions with psychiatric medications, some to avoid and then others just to keep in mind. So we're doing this from a high-level perspective, so this is not all-inclusive. We are going to compare pharmacodynamic and pharmacokinetic drug interactions, talk about some of the considerations for each, and then identify some of the relevant ones really just to keep in mind as you're caring for your patients moving forward. First thing, I wanted to put the brakes on, so why are we focusing on drug interactions? It's been identified that there can be a number of adverse outcomes from drug interactions, and this could be anything from adverse effects up to complete mortality as a result of some of these interactions. It increases hospitalizations as well as ER visits. There are a couple population trials that were done that identify a quarter to a third of patients who are admitted to the hospital, their admission is related to a potential adverse drug interaction. And about 50% of the one cohort, their emergency department visits were somehow related to the drug interaction, whether a direct result or sequelae as a result of that drug interaction. Can also result in treatment failures if there is an interaction that causes adverse consequences. If patients are discontinuing their medication because of that, that could be a treatment failure as well as have potential consequences for that disease moving forward. If a patient has schizophrenia and we're not treating them appropriately, that duration of untreated psychosis could continue and have more long-term adverse effects. And then other complications. Unfortunately, sometimes the drug interactions can lead to toxicity. We're going to talk briefly about hypertensive crisis that can cause end organ damage. We may see seizures. We may see other organ damage as a result of toxicity that can result from some of these interactions. So really trying to prevent adverse consequences with the medications that we're using. So trying to do no harm. So in looking at this, we are going to divide the drug interactions into two categories. So pharmacodynamic and pharmacokinetic. So pharmacodynamic, really focusing on what the pharmacology of the medications, what those meds do to the body. And pharmacokinetic, focusing a lot more on what the body does to the drug with the specific focus on metabolism. So this is actually a rendering of cytochrome P450 2D6, which we'll come back to in a little bit. We will look at glucuronidation briefly at the end, but most of the focus for the pharmacokinetic piece, just for the sake of time, is going to be on the P450 system. So let's get started with pharmacodynamic considerations. So we may see drug interactions that are pharmacodynamic that fall into two camps. So one being synergistic effects, where the actions of one medication work in tandem to bolster the effects of another medication. In some cases, that may be exactly what we're hoping for. So the example of carbidopa-levodopa. So the carbidopa is going to prevent the breakdown of the levodopa out in the periphery of the body so that it can actually work in the brain. That would be great synergism, where they're working together and those actions really are going to bolster what we're hoping for. In other cases, it may be detrimental. In cases where we have multiple agents that have anticholinergic effects, multiple agents that maybe have serotonergic effects, we can see increased toxicity as we continue to add to that particular burden, which may put some patients at risk. On the other side, we can see some antagonistic effects where the medications are working completely against each other. So some of those examples may be with dopamine agonists and antagonists. So if there's a patient who potentially is on an antipsychotic medication, risperidone, for their bipolar disorder, and they also have restless leg, and maybe they're given a dopamine agonist. So they're on ropinirole. Well, we're going to have some competition for those dopamine receptors. In some of our younger patients, you may see patients who are on stimulants as well as on antipsychotic medications. So an amphetamine or methylphenidate that's increasing the dopamine and norepinephrine and trying to work on those receptors, and then another agent that's blocking it. They may be working in separate directions. And in some cases, that stimulant might even make some of the symptoms for which the patient's on the antipsychotic worse. Other pharmacodynamic considerations that I just wanted to point out, and again, not overly inclusive. So lithium's elimination renally can be impacted very dramatically by diuretics, which are going to change the amount of sodium that gets eliminated, or how often the body wants to reabsorb the sodium and may take the lithium instead. If they're on nonsteroidal anti-inflammatories, this includes ACEs and the classes of ACEs and ARBs, their actions on the kidney can have a direct impact on how much of the lithium that's being excreted. Because that's such a narrow therapeutic window, that could have really significant ramifications with potential renal damage that becomes irreversible, or even neurologic damage if the toxicity is severe. Other considerations that tend to be things we really want to avoid: multiple agents that prolong the QT interval. So if we're looking at combination antipsychotics, if patients have to use other medications, making sure we have that comprehensive list. If they are ill and end up on an antibiotic, potentially a fluoroquinolone, and they're on 2 agents that are prolonging their QT interval, we don't want them to go on to develop any cardiac arrhythmias. Other areas under pharmacodynamics that do move into the increased severity range would be with our monoamine oxidase inhibitors. This is kind of a teaser for 2 weeks when our whole session is focused on MAOIs. But with the monoamine oxidase inhibitors, inhibiting that enzyme that's going to break down serotonin, dopamine, and norepinephrine, there actually are contraindications to the use of any agent that would also increase those neurotransmitters. And the reason for that is the potential risk for a hypertensive crisis or the development of serotonin syndrome. So I just took a quick snapshot from one of the prescribing information guidelines for specific medications that are called out that have had reports or there are documented interactions where we see potential toxicity. So this would be one of the hard stop, definitely avoid combinations if we can do so. There are rare instances where they're used together, and it does require pretty significant monitoring. So pharmacodynamic, we definitely have drug interactions to consider, but I think when many people think of drug interactions, they think about the pharmacokinetic ones. So our pharmacokinetic ones, we're going to focus on the metabolism and zoom in specifically on induction and inhibition. So induction of the enzymes, and we're going to focus mainly on cytochrome P450. So this takes a little bit more time. You may start to see effects after a few days, but the full effect won't be in place for weeks to a month or 2 after the medication has been started. The reason is that these medications actually can activate some of the genes, and they stimulate production of additional copies of these enzymes. More copies of the enzyme means more capacity to metabolize. Greater capacity to metabolize can lead to lower concentrations and diminished efficacy. So induction, more metabolism, but less effect. So they do move in opposite directions. And since it takes time, that's why we've got the little tortoise here on that side. On the flip side, with inhibition, many of these agents will bind specifically to the enzyme itself, and we can see an immediate effect where that enzyme is now no longer able to function at its true capacity. There are 2 classes, so reversible and irreversible. The irreversible ones, once they've bound to that enzyme's out of commission, and we're not going to see new enzymes made for a while. For the reversible ones, they may bind and let go, so you may still see some additional activity, but it's much less than if that wasn't in place. So binding to that enzyme, it's not able to function, less metabolism. We get higher concentrations and potential for toxicity. And again, the hair down here, just because that can happen right away. So something to keep in mind as we're adding medications on board is when should we be checking in to see if this is having an impact. Maybe in a couple days versus we need to check back in a couple weeks or a month or two. And because the enzymes we're focused on, the cytochrome P450 enzymes, I picked some specific examples of these three families of enzymes. Cytochrome P450, the 1 family, is impacted by the aromatic hydrocarbons in tobacco smoke and has an impact on a number of our medications. Clozapine and olanzapine, we're going to look at some data in just a minute, because it can have a pretty significant impact. The family of 2 and 3 actually metabolizes a large portion of our other medications, benzodiazepines, antidepressants, antipsychotics. So these really are the focus of, even if the medication itself doesn't induce or inhibit, it may potentially impact the concentrations or side effects of the medications that you're using. So what does this look like? For our inducers, there is a link at the bottom of both this and the inhibitor table that will take you to a drug interaction table that the Indiana University, that they maintain. And it actually has a robust amount of information. So I would definitely encourage you, if you've not done so, to take a look at that link down there. For the inducers, they've identified a number of inducers that we may use in the treatment of mental health conditions. So what this means is we may see some additional increases in the enzyme activity itself. I want to point out for 2D6, we don't see significant robust induction. One of the reasons for that is we see a greater range of 2D6 activity as a result of genetic polymorphisms. So if you have a patient that has multiple copies of this enzyme, they might be a rapid metabolizer or even an ultra rapid metabolizer, while as other individuals may have only 1 copy or even a defective copy of the 2D6, and they may be a poor metabolizer and they're not able to do that. So not as influenced by the inducers. 1A2, 3A4 definitely have an impact with these medications. But again, it takes some time. This is not something that we're going to see right away. The medication is added on board, and then we need to wait a little while to, for the body to make those new enzymes, and then for us to reevaluate, okay, now what do those concentrations look like? Do we need to make some dose adjustments? Potentially increasing the dose so that we maintain the concentrations. And as promised, so tobacco smoking, the aromatic hydrocarbons that happen as a result of the combustion of the tobacco have a significant impact on the 1A2 enzyme. And we can see an increase in the metabolism for 2 of our antipsychotics, clozapine and olanzapine specifically. This trial was a meta-analysis that looked at a number of studies, and they looked at patients who were on clozapine or olanzapine and had a designation of smoker or non-smoker. And then they were looking at the concentration to dose ratio, and they wanted to compare those that were smokers to those that were non-smokers and see if there was a difference in that concentration to dose. That's the CD ratio. And what they found was that on average, yes, the smokers had a significantly lower concentration to dose ratio than the non-smokers have. And when they pooled it, it was pretty significant, to the point where they're recommending 30 to 50% dose adjustments to be able to get similar concentrations. So may play a much larger role for those of you that are taking care of patients' transitions of care-wise. If they're in the hospital not smoking and they're stable, as they're getting discharged and they may pick up their habit again, that may require some dose adjustment. So as they start smoking, those concentrations will go down. We don't want them to get subtherapeutic. We may have to increase those doses. So just something to keep in mind, but relatively significant that it would require up to a 50% dose adjustment. On the other side are inhibitors. We have quite a big class, so a number of our antidepressants are identified as enzyme inhibitors. Now there's a few different categories or a few different ways that these are quantified. As the medications are initially released, oftentimes you'll see Ki values. Now for a number of the Ki values, they're conducted in a lab setting. So they're done in vitro. One of the problems with that is we can see really large ranges depending on what test agent that they're using, as well as if they're, which animal they're using, or if they're using human cells, and if, especially with 2D6, what that genetic makeup may be. So for a number of these values, we can see relatively large ranges, and they're not as clearly predictive of what we'll see in clinical practice. So this same table from Indiana University, they've actually done additional studies related to the enzyme inhibition, and they've created another key where the 1+ is for inhibitors that increase the plasma area under the curve, so the amount of medication that that is being delivered under twofold, so more than 1.25, but less than 2, or they see a 20 to 50% decrease in clearance. So we're definitely seeing an impact, but maybe not quite as significant. For moderate, it's more than a 2-fold increase in the plasma AUC, or a 50 to 80% decrease in clearance. And then for the strong inhibitors, more than a 5-fold increase in the plasma AUC and greater than an 80% decrease in clearance. So really seeing the clearance be minimized by more than 3/4 of what the activity had been previously. So as you'll see, unlike the inducers for inhibitors, they can inhibit the 2D6 enzyme. So if that enzyme's present, they can bind to it and make that less effective. So it's a much bigger concern for inhibitors than it was for inducers. And we have quite a few of our antidepressants that play a significant role in inhibiting some of these enzymes, which if patients are on multiple medications, that means we have to be watching for potential adverse effects that hadn't been problematic before. So we may have to do some dose adjustment. But cytochrome P450 is not the only one where we may have to do some dose adjustment. This combination may be used in a few different areas, and I wanted to make sure we included it because this one actually is a pretty significant one. So glucuronidation is another enzyme that's involved in metabolism. Specific to this example, it's metabolism of lamotrigine. So valproic acid is an inhibitor of this enzyme. It can increase the lamotrigine concentrations and has the potential to increase the risk, especially as somebody's starting lamotrigine, or you're starting the valproic acid on a patient on lamotrigine, for having the patient develop Stevens-Johnson syndrome. Now, why might that be a big issue? Because that would require discontinuation of the lamotrigine, and that may remove that as an option for the patient. So as you can see here, the bottom in each of these graphs, it's lamotrigine concentration on the y-axis and time on the x-axis, with the dotted line showing a decrease in concentrations at baseline, but when we add the valproic acid on board, you see that higher level. So patients are exposed to greater concentrations over a longer period of time, which is why there are specific dosing changes recommended if patients are using that combination. So this would be one of the areas where, not that we can't use it, but we need to be mindful and make sure we're making those changes. So in general, what do we do with all of these interactions? Because they could go in a few different directions. It really is going to be a patient-focused approach. There are only a handful that really are your hard stop, no, we're not using those, the MAOIs being the example. But if you have a comprehensive medication list, everything that the patient's taking, prescription, non-prescription, illicit or not, providing education, if we're adding things, starting low and going slowly, and making sure we're communicating and monitoring. We're watching for changes, but what are we watching for? the symptoms to come back, adverse effects to show up, really being able to engage the patient and their family or caregiver and giving us that information if we do need to make additional adjustments. And because sometimes we need to make adjustments and it's not our medications that are causing the problem, even though there may be other medications, large classes of medications that weren't an inducer or an inhibitor, it doesn't mean they're not impacted. So if other individuals, other providers, their family practice doc, maybe they have an infectious disease physician, if they're adding other medications, they may also impact ours. So really important to have that collaboration and coordination of care. So just to wrap up, definitely a consideration with the medications that we use. We can see either of those classes of medications causing interactions. So getting that comprehensive list and making sure that we're talking with the patients and their caregivers to safely use the medications as much as possible. And with that, I will turn it over.